suspicion of marrow involvement and hemophagocytosis. This is for bone marrow examination and that of the culture. So next, move on to one by one scrub typus. Okay, we know that the causative organism for the scrub typus is Orientia tutsugamishi. It's a chigger born from the larva of tromboculid mite, that is a vector. Basic pathophysiology in this tropical illness, the organism is going to cause vascular endothelial damage. So it is going to cause the breach in the endothelium. So subsequent vascular injury leads to organ dysfunction with a microthrombi formation with the activation of procoagulant system, which can have multi-organ involvement. So usually the incubation period is going to be 1 to 3 weeks. So they present with fever, headache, myalgia, breathing difficulty, delirium, vomiting, cough, jaundice. Very difficult to differentiate just based on the clinical manifestation. One specific finding for the scrub typus, you have to search for typical eschar in the hidden areas of the body, particularly underneath the breast tissue, groin, axilla, behind the ear pinna. So it can have a complication with the overwhelming pneumonia with a severe ARDS. So severe fulminant liver dysfunction, aseptic meningitis. Scrub typus can have myocarditis with a non-specific STT changes. So sinus tachycardia is most common manifestation of myocarditis. Patient worst scenario can have DIC manifestation with the coagulopathy, with the INR, with a low fibrinogen, with a low platelet count, with the bleeding manifestation. This is the worst complication of scrub typus. How to differentiate from other tropical infection, even though it is not so specific for the standalone scrub typus, other than this eschar, they usually have some sort of regional lymphadenopathy. Fever can persist for more than or equal to 8 days. Elevated CRP, it is non-specific. So elevated ALT, AST, non-specific. So defervescence within 48 to 72 hours after specific therapy. Means if you start them on doxycycline, okay, so they will be get rid of the symptoms. So like within 48 to 72 hours. All these things gives a clue for the diagnosis of scrub typus. So against the scrub typus, bone pain, dengue, bleeding manifestation because of thrombocytopenia, dengue, loose stools, typhoid with enteric fever. So WBC count, usually leukopenia can happen in leptospira or dengue. So thrombocytopenia less than 50,000, though not specific to dengue, it can happen. So bilirubin, usually remember most of the tropical infection except malaria and hepatitis A, they have transaminitis with an elevated enzyme, but usually they don't have a bilirubin of more than 2. Very, very important practically. So more than 500 AST, dengue, less than 100 malaria, more than 500 hepatitis A. So though they are not so specific, combined together all these clinical manifestation, we can narrow down, rule out, rule in whether it is a scrub typus or not. Very, very important. So when it comes to lab diagnosis, Weil-Felix test, it is highly like having a poor sensitivity. It is not sensitive, okay, and specific. So that is the problem with Weil-Felix. Particularly, even though little bit sensitive, it is not specific. False positive reports are high possible when you just rely on the Weil-Felix. That's why nowadays we are not doing Weil-Felix because of the false positivity. Indirect fluorescent antibody, it is considered as gold standard. ELISA based IgG, IgM antibodies, sensitivity and specificity is going to be more than 90%. Practically, we do scrub IgM, which is having a good sensitivity and good specificity as compared to Weil-Felix. So treatment, first line is doxycycline. So second line, we can consider azithromycin. So or rifampicin, chloramphenicol as an alternative in children and pregnant women. Remember, very, very important for your MCQs, all these alternative therapeutic option. When it comes to leptospirosis, the causative organism is Leptospira interorgans. Source of infection, it is from the direct